Now the part 2 is that triage guidelines. All patients should be assessed within 10 minutes of arrival. Full patient assessment should not be routinely completed in the triage area when other patients are waiting to be triaged. The triage assessment should generally take no more than 2 to 5 minutes. Obtaining sufficient information to determine the urgency and identify any immediate care needs. All information obtained should be recorded on the registration sheet. Rapid assessment should be performed when there are 2 or more patients waiting to be triaged. The priority of care may change following a more complete assessment or patient signs and symptoms evolve. Level 1 and level 2 patient should be placed in a resuscitation area and have a complete assessment immediately. Level 3 patient need full vital sign assessment to determine that it is safe for them to wait for treatment. Level 4 and 5 patients may have their vital signs delayed until re-evaluation in the waiting area or treatment area. The triage assessment. First impression, quick look. What is quick look? Initial impression of triage personnel. Then chief complaint and its duration. And assessment of chief complaints. The objective of evaluation is, did the symptoms start? What are you doing when it started? How long did it last? Does it come and go? Is it still? Then regarding the important thing in the triaging is the pain scale. The pain scale is from 0 to 10. If the patient has a pain from 0 to 2, it is mild. 3 to 6, it is moderate. 7 to 8, it is severe. And 9 to 10, unbearable or patient. So the triage nurse will give the pain scale according to the severity and the look at the patient or the expression of the patient according to the scales designed for this assessment. This part of triage assessment may be deferred to the treatment area if the patient requires rapid access to the care and intervention level 1 or level 2 patient. The objective evaluation includes physical appearance, color, skin, activity, degree of distress, moderate distress, no acute distress, emotional response, anxious, indifferent, complete vital signs if time allows, or necessary for assignment of triage level. Then patient can be retriaged. To ensure the patient status is not deteriorating after initial triage, retriage should occur at time interval recommended for medical reassessment. For level 1, continuous care. Level 2, within 15 minutes. Level 3, 30 minutes. Level 4, 60 minutes. And level 5, 120 minutes or up to 2 hours. The documentation standards is very important. The documentation of the triage assessment sheets are printed and need to tick accordingly. Date and time of assessment, vital signs. If the triage nurse feels that some problem in the digital apparatus, she can manually check the vital signs, especially blood pressure or the temperature. Saturation of the patient. If patient is in respiratory distress, she must check the respiratory rate of the patient. Must ask the allergic history, chief presenting problem, then see how the patients coming on by ambulance, by wheelchair, by stretches, by walking. So the mode of arrival of the patient. Then there must have been pain scale that I have already mentioned. Then fall scale. Fall scale must be assessed in children and elder people or the person who are having some other problems or disables. How you check? It is very simple method. Just keep one chair in front of you and ask the patient to come and sit on the chair. See how the patient is sitting. If she prone to fall down, then you can give the scale according to that, how much risk the patient has to fall. Then you can allocate the initial triage category. In the last, name of the triage nurse, read triage category with some time and reasons, assessment and treatment area allocated, any diagnosis, first aid or treatment initiated. The factors which influence triage design and operation include number of visits, number of patients requiring rapid intervention, availability of healthcare provided in the emergency department treatment area, availability of specialty services, environmental, legal, and administrative issues. Many times the patient is waiting for the orthopedic consultation or the ophthalmological consultation or the ENT consultations. So there's a rush of the patient in the waiting area and already triaging patients are there. So it is very important that these things are affecting on our triaging levels. So according to the Canadian Triaging and Acuity Scale, what is the level 1? The level 1 is also called the resuscitation. The conditions that are threatening to life or limb, or there is an immense risk of deterioration requiring immediate aggressive intervention. So usual presentation is the code arrest, patient with cardiac or pulmonary arrest, major trauma, patient having head injury with the GCS less than 10 or severe burn more than 25% with airway problems, chest or abdominal injuries with any or all of altered mental state, hypotension, tachycardia, severe pain, respiratory sign or symptoms. Then shock states, condition where there is an imbalance between oxygen supply and demand or utilization, like in sepsis syndromes, hypertension and or tachycardia and possibly bradycardia in advanced or pre-arrest situations. Unconscious patients, it is maybe due to the CNS or metabolic disturbance or airway problems or due to hypoglycemia. So these are the conditions. Then severe respiratory distress, like patient saturation less than 90%, COPD exacerbation, chronic heart failure, patient near death asthma, unable to speak, cyanosis, lethargic, confused, tachycardic or bradycardic. So, and patient having typical patients which fall in this group are number 1, who are non-responsive. Number 2, their vital signs are absent or unstable. Number 3, severely dehydrated. Number 4, severe respiratory distress. So, which category of the patient falls in the resuscitation? Again, I will repeat. Number 1, patients who are non-responsive. Number 2, absent or unstable vital signs. Number 3, severe dehydration. Number 4, severe respiratory distress. Now comes the level 2. This is also called emergent. Conditions that are a potential threat to life, limb, or function requiring rapid medical intervention or delegated acts. So, the time of physicians to act is less than or equal to 15 minutes. The conditions which fall in this category include altered mental state due to infection, inflammatory, ischemic, traumatic, poisoning, drug effects, metabolic disorders, dehydration can all affect sensorium from simple cognitive deficit to agitation, lethargy, confusion, seizures, paralysis, coma. All patients with altered mental state should have a rapid blood sugar screening test. So, the triage nurse must have a glucometer and she should screen for the hypoglycemia to all patients with AMS, head injury patients. This problem appears in several triage levels. The more severe or high risk patients requiring a rapid medical assessment. To determine the requirements for airway protection, CT scanning, or neurosurgical interventions. These patients usually have an altered mental state. So GCS is less than 13. Severe headache, loss of consciousness, confusion, neck symptoms, and nausea or vomiting can be expected. Third one comes the severe trauma. These patients may have high risk mechanism and severe single system symptom or multiple system involvement. These patients should reveal normal or nearly normal vital signs. If the vital signs are abnormal, then upgrade to level 1. These patients may have moderate to severe pain and normal mental state. Fourth one is the neonates. Children less than 7 days are at risk for hyperbilirubinemia, undiagnosed congenital heart abnormalities, and sepsis. So they need emergent ED treatment and have a prompt physician's assessment or verbal review. Number 5, eye pain. If the patient having a chemical exposure either due to acid or alkali cause severe pain and the scale can be between 9 to 10 or 8 to 7 to 8. Therefore, these patients should have a level 2 and these patients must be seen between 15 to 30 minutes either by the ophthalmologist or by the healthcare provider in the emergency department. Number 6 is the chest pain. This is one of the most difficult presenting symptoms for triage nurses and emergency physicians. There are so many ways in which cardiac ischemia presents with frequently faced long and detailed assessments that do not always lead to definite conclusion. Patients with non-traumatic visceral pain are most likely to have significant coronary syndrome. Careful documentation of the activity at the onset, the duration of each episode, the character, the site, the radiation, associated symptoms, aggravating and alleviating factors, and risk profile all influence the ability to predict the presence or absence of significant coronary disease. Visceral pains is continuous more than a few seconds and almost always more than 2 to 5 minutes and is described as a pressure ache, squeezing, heaviness, burning, or just a discomfort. If there are associated symptoms such as sweat, nausea, and shortness of breath and are radiating to neck, jaw, shoulder, back, or arm, then the likelihood of serious etiology increases dramatically, especially in females if they have a epigastric pain radiating to the scapula or the back must be carefully evaluated and sent urgently to the treatment area. Some sudden sharp pains can be associated with chest wall problems. These patients usually have sharp pains that are severe, sudden, persistent, or associated with other symptoms like short of breath, syncope, presyncope, or significant risk factors are present. The sharp pains, which are not severe, are easily reproduced by palpation or aggravated by cough, deep breathing, or movement. With normal vital signs, can have a delay in physician assessment and can be given level 3 or level 4. Previous MI, angina, or pulmonary embolism. Patient with a prior history of these conditions should be level 2, no matter what the character of the pain. Overdose. Intentional overdoses are particularly unreliable when trying to determine which agents have been ingested and the actual quantity. These patients require early physician assessment. Abdominal pain. Pain severity alone cannot predict whether serious surgical or medical conditions are present. Visceral pains, constant ache, pressure, burning, squeezing, with associated symptoms like nausea, vomiting, sweat, radiation, or rebreathing pains, with vital signs, abnormalities like hypotension, hypotachycardia, or fever are much more likely to be serious problems, which require prompt investigation, treatment, or pain reliefs. Crampy, intermittent, or sharp brief pains without vital sign abnormality usually may be delayed. There is a significant overlap between benign condition and catastrophe such as ruptured abdominal aortic aneurysm if the age is more than 50 years. Ectopic pregnancy between 13 to 50, perforated viscous appendicitis if the and bowel obstruction, ascending cholangitis. This means that all severe abdominal pain with 7 to 8 pain scale should cause providers to be particularly wary of visceral pains or very sudden pains, particularly with other associated symptoms. GI bleeding. Upper GI causes are more likely to cause instability, vomiting, gross blood, coffee ground emesis, and melena are typical for upper GI bleed source of the bleeding. Maroon stools, dark blood, or white blood can also be from upper GI source but are more likely to be lower GI. The source is not as important as how to deal with the patient with hemodynamic instability. One set of normal vital signs carries no guarantee of hemodynamic stability. CVA. Patients with major neurological deficits may require airway protection or emergent CT scanning to determine criteria for thrombolysis, anticoagulation, neurosurgical intervention, or other procedures. If the time of onset of symptoms is less than 4 hours, then time to CT scanning is critical element in treatment strategies. Asthma. Severe asthma is best defined with combination of objective measures, forced expiratory volume, peak expiratory force rate, oxygen saturation, and clinical factors which relate to the severity of symptoms, vital signs, and history of previous severe episodes. The best measure of severity and guide to therapy is some form of spirometric testing. However, it is not necessary in the triage area. Depends upon the saturations. Dyspnea. This is a subjective and may correlate poorly with lung functions. So, the patient having dyspnea due to chronic heart failure, COPD, pulmonary embolism, pneumothorax, pneumonia, CROP, epiglottitis, anaphylaxis, or a combination of problem. So, onset and duration of the symptoms is the very important. Anaphylaxis. Severe allergic reactions can deteriorate rapidly. Patients with a history of asthma are at a particular high risk of death. Suspicions of problems should be present if there are any respiratory symptoms. Vaginal bleeding, acute pelvic, lower abdominal pain. Patients with vaginal bleeding and or acute lower abdominal pain should be assessed for possibility of ectopic and other serious problems associated with pregnancy, even if the pain is only moderate 4 to 7. So the patient must be resuscitated at level 2. Serious infections, patients with bacterial infection or sepsis syndrome usually appear unwell and will have an abnormality in one or more physical signs such as mental state, vital signs, or oxygen saturation. Fever. Young children, temperature more than 38 in children under 3 months. Fever with signs of lethargy at any age, which results in a prompt assessment by the physician to consider serious bacterial illness such as meningitis. Children with lethargy, poor feeding, vomiting, with or without a fever, should have very prompt physician assessment or a contact for advice on intervention. Vomiting and diarrhea with suspicion or signs of dehydration. The signs of dehydration are not always reliable, particularly in young patients. Acute psychosis, extreme agitation. These patients may be suffering from metabolic disturbance, poisoning, or other organic problems. If the acute psychosis, agitation is a part of known ongoing psychiatric illness, the patient will have to be evaluated. Diabetes. Medic alert bracelets or history from others, physical assessment, vital signs, bedside glucose testing will all be useful identification of diabetes. So all patients with hypoglycemia or the previous history coming with signs and symptoms, the triage nurse must check his blood sugar. Headache. The presenting complaints appear in a multiple triage levels. There are significant concerns about delays in diagnosis. So there can be a subarachnoid, epidural, subdural, meningitis, and encephalitis, which may have several overlapping features with migraine. So these sort of patients should be leveled 2 so that the patient can early discharge. Severe pain. When a patient claims to have a pain of 8 to 10 and does not appear to be in distress or appear to have anything, you expect to have intense pain. It is helpful to ask what their most painful experience and had been before. The first pain anyone has is by definition a 10 over 10 if they have had a child. A broken bone, renal colic, migraine, or other condition expected to cause severe pain, and their current pain is being compared with one of these entities. This may help you to decide which triage level is appropriate. You may also want to obtain a verbal order from the physician for analgesics. Drug withdrawal, delirium, or patients who are on chemotherapy are all level 2 patients.